next generation sequencing, and the first genomic studies in acute myeloid leukemia quickly followed, and it refined the molecular classification of both acute myeloid leukemia and acute lymphoblastic leukemia thereafter. Next, please. So if you see this diagram, it shows that we start with morphology. Morphology is the first step to the diagnosis of acute leukemia. And gradually, we have to do flow cytometry for lineage assignment in the current context. And this flow cytometry gradually evolved into cytogenetics and molecular studies. And finally, this conglomerate of classification techniques gave rise to the appropriate clinical management because the lineage assignment got more refined and there were risk stratification based on the cytogenetic and molecular studies. May I have the next one, please? So if you classify acute leukemias, could I have the next tab? Keep on tapping, yes. So you have acute lymphoblastic leukemia lymphomas, you have acute myeloid leukemia, and you have a category of leukemias. Next, please. Keep tapping. We have a group of leukemias which are nothing but a biphenotypic or mixed phenotypic acute leukemias based on the phenotypes that are present on the cell surface and in the cytoplasm and in the nucleus. So if when you talk about the B lineage acute lymphoblastic leukemia, you have characteristically the CD19, 10, 20, 22, and you have the cytoplasmic 79A and the immaturity marker of TDT. Whereas in the T lineage acute lymphoblastic leukemia, you have the pan-T marker that is CD3, CD75, and you also have some immaturity markers like TDT, which is common to both, and you have the CD4 and CD8, which are the differentiation markers, along with some markers of immaturity in terms of CD1A and CD2. But the linear specific marker is CD3. You can study both cytoplasmic CD3 and the surface CD3 in T-lineage lymphoblastic leukemia. When you switch over to acute myeloid leukemia, you have myeloid markers, which are nothing but cytoplasmic MPO. You can have CD13, 33, which are maturation markers. CD117 is a marker of immaturity, and CD15 is a marker of differentiated granulocytes. Many of these myeloid leukemias have a monocytic differentiation. When you have a monocytic differentiation, you have the monocytic morphologic characteristics. In addition to that, you have the monocytic markers by flow cytometry, which are positive for CD64, 14, 11B, 11C, and the lysozymes. Many of these acute myeloid leukemias have erythroid differentiation as well as megakaryocytic differentiation. When it is erythroid, you have the CD71 and CD235A, which are nothing but transferrin receptor and the glycophorin A on the cell surface. Similarly, when it is megakaryocytic or megakaryocytic acute myeloid leukemia, you have the presence of CD41, CD61 as the markers, and CD36 also as markers of megakaryocytic differentiation. You'll have a small subset of patients who will be mixed phenotypic acute leukemia, or you can say that biphenotypic acute leukemia, or you can call it acute leukemia of ambiguous lineage, where you will have the markers either of myeloid and monocytic, or myeloid of with a B lineage marker or T lineage markers. So you can have B myeloid, you can have T myeloid, and you can have BT acute lymphoblastic leukemia because of the presence of both B and T markers of them. So in the myeloid, the characteristic marker is cytoplasmic MPO, whereas in the monocytic side, you have number of markers, but at least two of them should be positive to call it myeloid with monocytic differentiation, either 1464, 1611C or lysozyme. But when it comes to B, the characteristic marker is a strong CD19 with either of the presence of 10, cytoplasmic 22, or cytoplasmic CD79A. But CD19 is the lineage marker for B lineage. Sometimes when your CD19 is weak, you should have at least one of these, uh, at least two of these markers of 10, cytoplasmic 22 or cytoplasmic 79A. So T lineage, you should have strong cytoplasmic CD3 with antibody to beta epsilon chain of CD3. So based on the presence of these markers, either myeloid or B lineage or T lineage, you categorize them as B myeloid or T myeloid or BT, acute leukemia of ambiguous lineage. Because here the lineage is not very refined. Still, the cells are pretty immature for the differentiation pathway to happen. Next, please. So when you come to the French American British classification, which was first enunciated in 1976, it took morphology and cytochemistry as the primary modality of diagnostics criteria. When you speak about ALL, you had just three morphology types. You had the L1 subtype, you have L2 and the L3. L3 used to be called the Burkitt morphology type, where you call it as Burkitt leukemia lymphoma. So L1 used to have small lymphoblast, L2 intermediate sized lymphoblast with heterogeneous population of blasts, both small and intermediate sized cells. Whereas in L3, you had large homogeneous blasts with abundant basophilic cytoplasm and prominent of cytoplasmic vacuolation, which I will show you sometime later when I show you the morphology. Similarly, on the myeloid side, you had right from M0. M0 was AML of undifferentiated type, where the MPO is plus minus. Myeloperoxidase, when you stain cytochemically, will either be positive or either be negative. And M1, M2, M3, 4, 5, 6 were based on the maturation. AML M1 is without maturation, M2 is with maturation. These things we don't read these days because most of the books have done away with this. But when you make a complete study of acute leukemia, these things will come in as the historical aspects of the classification. During my undergraduate days, we had nothing but French, American, British classification, which were evolved from 1976 until end of the 20th century. We had the French, American, British classification with many modified versions. But 2001, we got the first WHO classification. Next slide, please. So here, when you see the current fourth edition, 2017, and you see the proposed WHO classification, fifth edition, 2022, you find that there are differences in it, but there are retention of many of these entities as well. When you look at the left side, the fifth edition, you have many of these which were existing in the fourth edition. You have the B lymphoblastic leukemia lymphoma not otherwise specified. You have the same with high hyperdiploidy, with hypodiploidy, interstitial amplification of chromosome 21 or IAMP, ALL with BCR-ABL fusion transcript, ALL with BCR-ABL1-like features, and you have the KMT2A rearranged ALLs, and you have the ALLs with ETV6 RUNX1 fusion. These entities exist in the new classification as well. But what is different is when you talk about the ETV6 RUNX1-like features, it was not previously included because this is a new entity. It was provisional in the previous classification, but it has found a definitive place for diagnosis and treatment. You have the TCF3-PVX1 fusion, which was nothing but 119 translocation, which was there before. And you have the IGH interleukin 3 translocation, which is retained in the same classification as well. So TCF3 HLF fusion is also a new class entity. And finally, you have a category which is called as ALL with other defined genetic abnormalities. So they have a scope in which if you find some defined, repetitive, consistent cytogenetic abnormalities in this disorder, you will put them in this category. So the classification is not very different from the fourth edition of the classification. Minor changes has happened, and the PH like ALL has found a definitive place in the classification. Next. Why it is so, I will come to that later, because it has distinct prognostic implications and therapeutic connotations. So when you talk about AML, 2022 fifth edition and 2017 fourth edition, you find that the box in the red are the changes that has happened, and all other entities have been retained. Here you have AML with MLL gene, which is MLL is the previous nomenclature, KMT2A is the new nomenclature. So AML with KMT2A rearrangement, AML with MECOM rearrangement, AML with NUP98 rearrangement. You had NUP214 fusion with DEC previously and in both classifications, which have been retained. So if you look at the left and the right side, there are a lot of similarities in both the text. What is important is that all the cytogenetically and molecularly defined entities of fourth edition is retained in the fifth edition with the addition of these three. Previously, we used to have AML NOS when you don't have these cytogenetic abnormalities or molecular abnormalities, acute myeloid leukemias. Almost 40 to 50% of them used to be classified as AML, not otherwise specified. Used to morphologically define them as AML with minimal differentiation, without maturation, with maturation, myelomonocytic, monocytic monoblastic, pure erythroid leukemia, which has been taken off now, and acute megakaryoblast leukemia. So if you look at this side on the fifth edition, you have AML defined by differentiation. So what the fifth edition has done, it has two broad categories. One is acute myeloid leukemia with defining genetic abnormalities, which are these, and AML defined by differentiation, which are morphologic. So still morphology has been retained as it used to be defined in the fourth edition. May I have the next one, please? Next slide, please. So the recent changes in the diagnosis of acute myeloid leukemia is quite different in the fifth edition of the WHO. Here, the separation of AML has happened between the defining genetic abnormalities and the AML with defined or defined by differentiation. As I mentioned, there are two distinct types. So what we have done now, that we have done away with the 20% minimum requirement of blasts in the AML with defining genetic abnormalities. In the AML with defining genetic abnormalities, the percentage of 20% has been done away with if you have myeloid blasts, whatever may be the percentage, but if you have those genetic, either cytogenetically defined or molecular genetically defined, you call them AML. Whereas if you do not have a defining genetic abnormality, you could still classify them as AML defined by differentiation. So with the exception of BCR-ABL, AML with BCR-ABL fusion and AML with CBPA mutation, all other defined entities in the genetic category need not have 20% blast requirement, which is extremely important. You will still treat a patient as AML when the patient has got 5 to 10% blast, but has a AML type cytogenetic or molecular genetic abnormality. So that is the hallmark of the fifth edition classification. So introduction of a section of AML with other defined genetic alterations, a landing spot for new or uncommon AML subtypes will remain, because Every other day, you have a new molecularly defined characteristic coming in the literature. And if you find that there is consistent cytogenetic or molecular genetic abnormality, they will figure in this category as years pass by. So the WHO has left one box empty where all these newer defined entities will get classified in future. Next, please. So this is again making some distinction between the fourth and the fifth edition with some key changes that has happened. Removal of morphology alone as a diagnostic premise to make a diagnosis of AML myelodysplasia related changes. You know, there is an entity in the WHO 2017 called AML with myelodysplasia related changes. It has a diagnostic criteria where you had more than 20% blast or marrow blast with history of MDS, with or without a prior history of MDS, presence of MDS related cytogenetic abnormalities, presence of morphologic evidence of multilineal dysplasia, absence of both of the following: prior cytotoxic or radiation changes or radiation therapy, any recurrent cytogenetic abnormalities, what you find in this classification, about 8 of them. And what it says that multilineage dysplasia alone may not be sufficient for diagnosis of AML with myelodysplasia related changes in de novo AML with mutated NPM1 or biallelic mutation of CVPA, which used to be the hallmark of fourth edition classification. But if you go to the fifth edition, what it says, removal of morphology alone means you need not have to have multilineage dysplasia for a diagnosis of AML myelodysplasia related changes. If it is AML with those cytogenetic abnormalities, it will be AML MR if you find myelodysplasia related cytogenetic abnormalities. So update of defining cytogenetic criteria has happened. And in addition, we have a table of 8 or a set of 8 genes, which I will show you in the next slide, which will be important if present along with AML, which will raise the diagnosis of post-MDS or MDS-MPN category of AML, or AML arising post-MDS or post-MDS-MPN. MDS-MPN is MDS, myelodysplastic syndrome, and myeloproliferative neoplasm. And you will be surprised to know that even this MDS has changed in this fifth edition. Now it is called myelodysplastic neoplasm. So it is MDN and MPN. The presence of one or more cytogenetic or molecular abnormalities listed in the next table, which will be and or with a history of MDS, will be required for the diagnosis of AML-MR. So the refinement is very subtle. All that you get out of this fifth edition is that you don't have to have multilineage dysplasia. If you have the MDS type of or myelodysplasia neoplasm type of cytogenetic or molecular genetic abnormalities. Next slide, please. It will be very clear. Yes. Seeing this defining somatic mutations, which is in the red box, you have 8 set of genes: SLX1, BCOR, EJS2, SF3B1, which is present in the refractory anemia with ring sideroblast of olden days, and SRSF2, STAC2, UTF1, and ZRSR2. These 8 genetic abnormalities or molecular genetic abnormalities, if present, even without multilineage dysplasia, can be termed as AML with myelodysplasia related changes. So what used to be present in MDS, a complex karyotype, which is more than equal to 3 abnormalities, 5q deletion or loss of 5q due to unbalanced translocation, monosomy 7, 7q deletion, 11q deletion, 12p deletion or loss of 12p, monosomy 13 or 13q deletion, 17p deletion or loss of 17p. 17p deletion is usually TP53 mutation, isochromosome 17q, and the isodicentric X chromosome in the Q13 site of the X chromosome. So all these are finer entities. This is on the left side was 2017. You have all these 11, 16, 321, 13, 211, 512, 57, 517, 510. These are all translocations, which are balanced abnormalities, which were found in MDS MRC or AML MRC. In addition to the unbalanced abnormalities, which you all read even before this classification of fourth classification. Next, please. So why these classifications are changing almost every 7-8 years? This time it had changed in about 5 to 6 years, because large cohort of studies which are published in literature, the prognostication, the therapeutic implications, the long-term treatment outcomes are gradually changing the various treatment modalities. So a particular genetic abnormality, if present, if it gives an adverse prognostic implication, will be classified differently than something which is giving a favorable treatment outcome. So that is the reason why these classifications are changing almost very regularly in an interval of 5 to 6 years. So if you come to the brass tacks of ALL diagnosis, in olden days when I was a student, we used to label these lymphoblasts like L1 morphology, L2 morphology. You can see that these are all L1 are very uniform size blast, very hardly any speck of cytoplasm, hardly any nucleoli, but high NC ratio and full of them in the marrow as well as in the peripheral blood. Whereas in the L2, you had a heterogeneous population of blasts, small, intermediate sized, some of them may be large, many of them will have prominent nucleoli, and the nuclear character will be irregularly clumped nuclear chromatin, whereas in L3 lymphoblast, you will have intermediate sized blasts with prominent intracytoplasmic and intranuclear vacuolations, as you find here with a deep blue cytoplasm. So this is the morphology of the ALL. So if you see these type of cells, we used to say that ALL. Then we used to do some special stains. It should be morphologically, cytochemically MPO negative. So MPO negative blasts used to be called with this morphology as ALL. Till the time we found that not necessarily they will be ALL, because many times flow cytometrically they are cytoplasmic MPO positive, even though they are cytochemically negative. So lineage assignment became very important, because the treatment of ALL is completely different. The treatment of AML is completely different. So the lineage assignment became very important. So no clinician today will treat a patient of ALL without flow cytometry or AML without flow cytometry. In addition to that, they need all those genetic markers for prognostication, for risk stratification. Next. So when you see a morphology like this is nothing but acute promyelocytic leukemia. Olden days, acute promyelocytic leukemia used to be a dreaded disease because it used to produce fulminant DIC and patients used to die of bleeding, but not anymore. This is the best AML to have because the treatment is very good. The arsenic trioxide and the all trans retinoic acid has created wonders in the treatment of acute promyelocytic leukemia. They don't die anymore. The long-term outcome is excellent. Almost 90% of the patients will get cured with all trans retinoic acid and ATO. Next. So when you come to a little morphologic deviation, sometimes these acute promyelocytic leukemias can have bilobed nuclei, and they will look like monocytes or monocytoid. So here comes the importance of flow cytometry and the importance of cytogenetics. If it is acute promyelocytic leukemia with a monocytoid morphology, they will be 15, 17 positive. They will be positive for 11, 17 or they will be positive for 517 translocation, because 1117 and 517 translocations in APML are variant translocations. Commonest is 1517 translocation. So nobody will treat this patient without getting the fish for PML RARA. On the other side, if you do a flow cytometry, all you know that these patients may show markers for monocytic differentiation. So you will call them AML with monocytic differentiation. Many times the pro-monocytes can look like pro-myelocytes. So it is important that you have to study them or characterize them by flow cytometric techniques and cytogenetics to rule out 1517 translocation prior to treatment. Next. So if you look at this slide, you can find that here are some intermediate sized blasts with moderately abundant deep blue cytoplasm. And you can see this distinct vacuolations in the cytoplasm and some in the nucleus. The same thing if you see in the bone marrow, you can find many of them having the same morphology as you saw it in the peripheral blood. So this will give you an indication that it could be the L3 type of lymphoblast, or in current terminology, the Burkitt's leukemia lymphoma. But presence of mere vacuolations in the cytoplasm or in the nucleus doesn't make it Burkitt's leukemia lymphoma till the time you demonstrate the 814 translocation, what you find in Burkitt's leukemia lymphoma. So it is important that you have to do cytogenetics to demonstrate that this has 814 translocation. Next. So if you see this, you can find that there are blasts on the left side, and there are some cytochemical stains which are positive on the other side. You can see that on the upper right hand, you can find that many of these blasts have cytoplasmic granulations, which are nothing but MPO positivity. So if you get blast and MPO is positive, in a resource constrained country like ours, you don't have to wait for flow cytometry to say that they are AML. Straight away, it is acute myeloid leukemia because you are demonstrating cytochemical MPO. Whereas many times what happens is cytochemical MPO is plus minus as it is in the lower outer quadrant. So flow cytometry is important. The morphology of these cells are classical blasts, but some blasts which are little variant in morphology. Some are with a lot of folds, some are monocytoid, some could be pro-myelocyte looking. So it is important that you have to look for the features of flow cytometry. So if you do a flow cytometry in acute promyelocytic leukemia, you will have certain characteristic flow cytometric features. They are CD34 positive, 117 negative, and HLA-DR negative. So you can label them as possible APML, advise cytogenetics for 1517. Okay, so the APML promyelocytes are CD34 negative, 117 positive, and HLA-DR negative. I told possibly the reverse, 34 positive and 117 negative. No, it is 117 positive, 34 negative, HLA-DR negative. Next. So sometimes you will have acute erythroid leukemia. In the 2017 classification, you have it as pure erythroid leukemia. Whereas in 22, they have removed this pure erythroid leukemia. So it is morphologically defined if they are all erythroblasts, which are more than 90% of the bone marrow cells. In olden days, we used to do pass in these smears, and if they are granular pass positive and MPO negative, we used to call them erythroblastic leukemia. So classification has evolved in that way as to why we need to morphologically define erythroid maturation. So in the new 2022, you have AML with erythroid differentiation. You have AML with megakaryoblast differentiation, which you'll see in the next slide. Next one, please. Next. Here you see, you have this blast and you have this megakaryocytic proliferation, with many of them are micro megakaryoblasts, very small, but they are all megakaryoblasts, which will be more defined if you do the CD4161 stains, which are nothing but glycoprotein antigens. Either they are glycoprotein 2B3A or 1B9, but those stain 41 and 61 are the markers for megakaryocytes. But here you can have the CD71 and 235A, which are the receptors for the transferrin receptors, or they are glycophorin A, which are on the surface of these erythroblasts. So AML-M6 and AML-M7 will get characterized if you do these special stains, including PAS, where the erythroblasts will be positive. Next. So again, when you have the megakaryoblastic leukemias, I have already said that you will have these blasts which will have a lot of blebbing. As you know that platelets get formed from the megakaryocytic cytoplasm in the form of buds all around it. So even though they are immature, still they will have or they will retain the budding quality. So these are subtle morphologic changes to suspect that there could be megakaryoblast leukemia. And when you see the marrow biopsy, often there will be desmoplastic, a lot of fibrosis. The aspirate may be a dry tap or a blood tap. You will not find a lot of cells in the aspirate, but they're all immature megakaryoblasts in the. And if you do a reticulin stain, the reticulin pattern will be increased. You do the CD4161, significant positivity of these immature cells with 4161. So you will have no hesitation in calling them acute myeloid leukemia with megakaryoblastic or megakaryocytic differentiation. Next. So as I mentioned that beyond morphology, we had flow cytometry, and flow cytometry is also evolving over the years. About a decade and a half ago, you had the 6-color, 8-color flow cytometers. You can see that these top two are BD-FACS Cantor 2. One is a 6-color, another one is a 8-color flow cytometer. This is my laboratory, so these pictures are from my lab. So after the BD-FACS Cantor 2, we acquired the BD-FACS Lyric, which is a 12-color flow, and then we had the DX-Flex from Beckman Coulter, which is a 13-color flow cytometry, and now the current platforms are even more colors than 12, 13 color. So why it is so? Because the flow cytometry cost is coming down. If the colors are more, just one tube will run all the important markers and you can come to a conclusion. Whereas lesser the color, you have to have more tubes. So that is the principle of flow cytometry, where you have just 3 things that you need to look at. Next, please. What you get is 3 components to flow cytometer. One is fluidics, other one is optics, and the third is the ledger and analysis of data. So in the fluidics, you have the cells which run in a single cell suspension. And in the optics, you have ledgers which are directed to the flow of the cells, and you get scatters. It could be forward scatter, it could be side scatter. And based on that, you have population of cells on the scatter plot. And these ledgers, usually the current generation of flow cytometers are 3 ledger equipments, and they emit light. And through the photomultiplier tubes, you collect those cells based on the color of the fluorophore or fluorochrome on the CD marker. So more the color, you have more fluorochromes being used in the antibodies. Next. So I need not go into the principles of flow cytometry. This is the basic fundamental diagram of flow cytometry. You have the sample which flows through the equipment through a laminar flow in a single cell suspension. And on this is hydrodynamic focusing. That's the principle of flow cytometry. And this is also the principle of many of the cell counters these days. And when the cells flow through these linear aperture and the laser beam falls on it, it produces the forward scatter, and they have photomultiplier tubes and detectors, and they're collecting lenses. So they will produce two-dimensional plots like forward and side scatters. Next, please. So what it does in the current scenario, the flow cytometers are multi-parametric because you are using large number of fluorochromes. Very rapid in the analysis of large number of cells. When you are doing diagnostic flow cytometry, you do about 30,000 cells or 50,000 cells. But when you do minimal residual disease analysis, you go up to 5 million cells, 10 million cells. So information can be obtained in a single cell label because every single dot on the scatter plot is a cell. And you can detect very rare events. Rare events are nothing but minimal residual disease or measurable residual disease. When patients have been treated for ALL or AML, and you are doing their ALL or AML MRDs. Next. So immunophenotypic or phenotyping in acute leukemias is very important. It is inescapable requirement for the diagnosis of acute leukemias because the antigenicity of the cells are important in the diagnosis. In terms of the aberrant expression of CD markers, the levels of expression, mild, moderate, or dim, asynchronous antigen expression. Sometimes you'll have loss of antigens, like sometimes you have loss of CD10, sometimes you have loss of CD15, loss of many of the markers as the patient get treated. You can have abnormal homogeneous expression of one or more antigens. So based on all these morphologic features and immunophenotypic characteristics, you can make a diagnosis and can detect abnormal populations in flow cytometry. Next. Gating strategy is important. Somebody who is well trained in flow cytometry will have their own gating strategies. And in that, you will have CD45 gated events. Everything will be CD45 gated, and then you select your population of interest. Next. Yes, you can see that the B lymphoblasts are CD45 negative to dim, whereas T lymphoblasts are dim to moderate in terms of CD45. And majority of the blasts will fall in the forward scatter and side scatter based on their size and cytoplasmic complexity. Next. We can move to the next. I think this slide is, yes, myeloid blasts are CD45 dim to moderate with moderate to high side scatter. So you can see that the P3 and P4 gates are usually the granulocytes and monocytes. This P2 actually is the population of interest, and they are gated, this green population. Next. Abnormal promyelocytes, as they are bigger cells with higher cytoplasmic content, they will be showing a larger side scatter. So that is how you will identify acute promyelocytic leukemia. Next, please. As I mentioned, T lymphoblasts will show moderate to bright 45 expression. T lymphocytes are usually brighter 45. B lymphoblasts are dimmer 45. Next. Yes, this is the table that we follow. This is the panel that we follow for BLL, AML, and TLL diagnosis and MRD analysis. So usually we follow the same tube pattern for diagnostic and also for MRD analysis. So AML is more complex, so more tubes. And if you have more colored machines, you will have lesser tubes. So this is a 8-color panel that I'm showing you because majority of the labs will have a 8-color flow cytometer. So this is how it is. And if you have more colors, you will have Pacific blue, you'll have AMCIAN, you'll have many other. The Beckman-Coulter antibodies will be different, the BD antibodies will be different. So you will create your own panel to understand the dynamics of flow cytometry, and will create your own panel for MRD by referring to literature and following the principles of what you call as leukemia associated immunophenotype, or you will use the DFN principle, which is called different from normal pattern of cells. Next. So I will now discuss few cases to illustrate how important and how uh, easy or difficult the diagnosis is. This is a 13-year-old female complaining of fever, headache, vertigo, and general rash all over the body with cervical lymphadenopathy and splenomegaly. Peripheral blood smear findings showed that there are 88% blasts in the peripheral blood. The bone marrow aspirate and biopsy findings show that there are a large number of blasts to the extent of 90% blasts, which are negative for cytoplasmic MPO cytochemically, which is consistent with acute leukemia. So acute leukemia is no doubt. So that's not enough. You have to say whether it is ALL or AML. And if it is ALL, whether it is BLL or TLL. Next. So this is the flow cytometry. You can see that the forward scatter site, the 45 gated 45 site scatter plot shows you a P2 gate, which is red in color, which is the blast population, which is almost 90% of the cells. And if you see the other two scatter plots, CD34117, it shows that the cells are CD34 positive. The Q1 population, quarter one, which is the upper inner quadrant. Then you see the CD19, 10 plot, which is 10 negative, 19 positive. So the cells are CD34, 19 positive. Next. And here you see that the cells are CD38 positive, the Q4 4 quarter. Then the cells are HLA-DR positive. Okay, and they are negative for 20 and negative for 22, or maybe dim for surface CD22. 22 is a B cell marker. Next. And here you see that the cells are cytoplasmic CD79A positive and positive for TDT, which is again a cytoplasmic marker. So with this, you can make a diagnosis. This is a BLL, which is CD10 negative. Next, please. So what is the diagnosis? So diagnosis is that it is acute lymphoblastic leukemia. Since the CD10 was negative, so we call it pro-B cell acute lymphoblastic leukemia. If CD10 would have been positive, you would have called it precursor B cell acute lymphoblastic leukemia, or BCPLL. It is abbreviated as BCP, means B cell precursor acute lymphoblastic leukemia. Most of the textbooks will write BCPLL. But when 10 is negative, in olden days it used to be called common ALL antigen, CD10. No more. That terminology is no more used. So this is a pro-BLL. And then patients are treated with standard protocols. Next. But this is a morphologic and flow cytometric diagnosis. So to risk stratify, you have to do cytogenetic analysis and molecular genetic analysis. I will come to that later. In case 2, you have a 15-year-old female, complains of fever, weight loss and weakness, signs of gum hypertrophy, no history of bleeding. On examination, patient has no lymphadenopathy or splenomegaly. The peripheral blood smear showed 60% blasts, which were positive for MPO. So the diagnosis is simple. Even before you do flow cytometry, since the MPO is positive cytochemically, you have no doubt that you are dealing with a patient of AML. So in this situation, you can straight away write acute myeloid leukemia. But in the previous case, you couldn't have written acute lymphoblastic leukemia with that certainty, because you could still have it as AML, or you could have it as ALL. So here you have the CD34, CD117 being negative. Which is your population of interest? Your population of interest is P4, which is red in color. So negative for 34117. And this blue population is actually the lymphocytes, and the P5 is your neutrophils. That is how the scatter plot is interpreted. And here in CD10 and 19, you have them 10 positive. So always neutrophils are 10 positive. You see green population is 10 positive. And this P4 population is also 10 positive. Okay, next. So here you find that they are 13 positive, which is a granulocytic marker, 33 positive, which is a granulocytic marker. You can see that many of these green population are also 33 positive because they are neutrophils. And here also you have many of these green things are seen along with 13, along with the red. So they are neutrophils. So the cells are positive for 1333. Next. So here you have done the cytoplasmic MPO and CD79A cytoplasmic, so which is negative, but they are positive for cytoplasmic MPO, which has this red cluster, and the green cluster is nothing but the granulocyte, which obviously will be positive for MPO. And on the other side, they are negative for TDT and cytoplasmic CD3. So you have to incorporate all these markers in your tubes so that every leukemic entity is excluded. Okay, the you had the blue color as lymphocytes, so they were negative for cytoplasmic MPO and cytoplasmic CD7, and they are positive for cytoplasmic CD3. So they are negative for cytoplasmic CD79A and negative for cytoplasmic MPO, the blue population, whereas they are positive for cytoplasmic CD3, which are nothing but T cell markers. So all those blue cells were T cells. 80% of the cells in the peripheral blood lymphocytes are T lymphocytes. Next. So if you see this plot, they are positive for CD64, which is a monocytic marker. They are positive for CD56, negative for CD14. Very small population is 14 positive. And very small population is CD14 positive as well. So primarily 64 being positive. Next. So what is your diagnosis? Your diagnosis is definitely it is acute myeloid leukemia even before you did the flow cytometry. And it has a monocytic differentiation because the scatter plot was little on the side scatter, the cells were more showing more side scatter, and rightly so you have CD64 being positive. So it is a AML with monocytic differentiation. So what it will, we haven't done cytogenetics yet. We haven't done molecular genetics yet. So if you classify it in the 2022 classification, you will have the second group classification where it is morphologically defined. But if it has a KMT2A rearrangement, it will move up to the first category. It will not be AML with monocytic differentiation. It will be AML with KMT2A rearrangement. How the diagnosis is changing. So it moves upwards, and KMT2A is a poor prognostic leukemia. So AML with KMT2A rearrangement will become poor in prognosis. So the clinician will take this patient upfront for transplantation following induction. So the clinician is not going to consolidate AML with KMT2A rearrangement because they will relapse. Straight away looking for a matched sibling related donor or a matched unrelated donor for transplant. So that's the implication of the diagnosis. Next. In the third case, you have a 26-year-old female admitted with complaints of weakness and rash all over the body with splenomegaly. Next. So straight away to flow cytometry. What you find is that you have these violet cells and these red cells which are flat on the ground. So here in the next 34 side scatter, you find that these violet ones are CD34 positive. And if you look at this 11734, you have 34 being positive, but they are negative for 10 and 19. They are positive for CD13, so granulocytic marker is positive. So 34, 13 is positive. Next. So if you look at here, you will find that the neutrophils are positive for cytoplasmic MPO, and they are on the negative side of cytoplasmic 17A and cytoplasmic MPO. Okay, next. So here you can find that the red ones are HLA-DR positive. They are 15 and 34 negative, heterogeneous. So some are positive for 33, some are negative for 33, and they are 56 negative, 14 negative. Next. Here what you find that they are positive for cytoplasmic series 61. Series 61 is what? Glycoprotein 2B3A. So you have a population which is positive for cytoplasmic series 61, and they are negative for CD235, which is a transferrin receptor, and glycophorin A. So this is very clear that you are making a diagnosis of acute megakaryoblast leukemia. Next. So it is a acute megakaryoblast leukemia. So acute megakaryoblast leukemia, the blasts could be MPO negative, and it is MPO negative here. And also they could be 34 negative, but here in this case, they were 34 positive. Variably positive because some of the myeloblasts will be positive for 34 and the megakaryoblast could be negative for 34. Next. So in this 50-year-old male who was admitted with complaints of fever, no lymphadenopathy or weight loss. Next. I'm just showing you the flow cytometry because that's important. So here you can find that there are a group of cells which are the small, this deep green color cells which are positive for 34, the lower right quadrant, and they are positive for 19, and they are positive for variably 13. Next. So myeloid and lymphoid markers, they are positive for HLA-DR. I'm just hurrying up by just mentioning the positive ones. Next. And you are finding them being positive for 38 and positive for immaturity marker of CD123. CD123 is a marker of immaturity. Next. 79A is positive. TDT is positive. So what it is? So it has myeloid and lymphoid markers. Next. So you can find that the CD19 is positive as well. Next. So three populations were identified. Next. So you have blasts and monocytes were positive for a higher side scatter and 45 being positive. Moderate side scatter with 45 positive monocytes. So there is a lymphoid population which was positive for 3419. There is a myeloid population which was positive for 34, 13, 33, variable positive, CD123. So these has got B and T lineages and myeloid lineages. So what it will be? Next. This is acute leukemia of ambiguous lineage in the current classification, or you can say that it is mixed phenotypic acute leukemia, myeloid B cell lineage, because the CD19 was strong positive with myeloid antigens being positive. So this is acute leukemia of ambiguous lineage. Next. This is the last case. 32-year-old male with complaints of weakness, fatigue, and has ecchymotic patches on the skin, no organomegaly, no lymphadenopathy. Hemoglobin is on the lower side, TLC is leukopenic, and DLC abnormal myeloid cells, which are 90%. Next. So here you can see that you have a large P2 cluster which has got a higher side scatter. And the cells are 117 positive, as I mentioned, and negative for 1910. And cytoplasmic MPO is positive, negative for TDT and cytoplasmic CD3. As I mentioned, that these cells are having high side scatter, 117 positive. And what is it? And CD34 is not here. I'll show you that. Next slide. And you find that these green cells are negative for 34. 33 is a granulocytic marker positive for them. 13 is a granulocytic marker in positive. So CD34 negative, cytoplasmic MPO positive, 34 negative, 13, 33 positive. The high side scatter. Next. This is next. Acute promyelocytic leukemia. As I mentioned, that they are CD34 negative, 117 positive, HLA-DR negative, and having high side scatter. Next. So once you have lineage assigned the leukemias, that's not enough. So what you need to do is you have to do cytogenetics, the next modality of diagnosis. Next, please. Now go back to the previous. So cytogenetics and acute myeloid leukemia and lymphoblastic leukemias have a great role in risk stratification and prognosis rather than in diagnosis, except for like something like 1517 in promyelocytic leukemia, 814 in Burkitt's leukemia lymphoma. So if you have precursor BALL, you need to know whether they are hyperdeployed or hyperdeployed. Hyperdeployed good prognosis, hyperdeployed poor prognosis by just conventional karyotyping. If you do AML with recurrent genetic abnormalities, usually which when you do FISH first and simultaneously conventional karyotyping, you will do many FISH, you use known probes, but conventional karyotyping is discovery mode. So you can discover a large number of karyotypic abnormalities. Next. So if you look at this slide, this is nothing but 922 translocation, balanced reciprocal translocation between chromosome 9 and 22, 9 and 22. So the chromosome number 22 is actually the Philadelphia chromosome. If you do the FISH in this by dual color, dual fusion FISH probe, you will find that there is a yellow fusion signal. Like in the upper nuclei, these are all anaphase cytogenetics. You can see that there is a fusion signal. And in this metaphase also, you can see a fusion signal. Okay, so there will be one green, one red, and one fusion. If it is positive for 922. Next. Similarly, I mentioned about KMT2A rearrangement in AML, very poor prognosis. You can find that the MLL gene or the KMT2A gene is highly promiscuous. Usually the chromosome 11 is involved. In addition to that, it can have large number of rearranged partners. Almost 65 partners are known for KMT2A rearrangement. So you can only do that by a KMT2A break apart probe FISH, which can only diagnose them which is the partner to chromosome 11. Next. So this is acute promyelocytic leukemia. As I mentioned, you have the promyelocytic morphology. Like the last case number 5, your TLC count was 800. You know, classical promyelocytic leukemias are leukopenic. They will have a count which is subnormal, and you will find abnormal promyelocytes. And when you do a marrow and do the flow cytometry, you have those characteristic features. But if you do the FISH, then you will find the 1517 translocation. Again, you can find that there is fusion signal here. Okay, so this is a metaphase preparation. You can find that the red signal is normal and the green signal is also normal, and there is a fusion when it is yellow in color. So red, green, normal, and fusion signal will be red, yellow in color, just like you have the 922 translocation. You can also have the break apart probe for 1517, because sometimes you can have variants. If you want to diagnose 1117 and 517, which are variant translocations, but still they are acute promyelocytic leukemia, you need to do a PML-RARA break apart probe study. Next. So these are the platforms which you use for molecular genetics. So I showed you the conventional karyotyping, I showed you the FISH. When you move to molecular genetics, you have many different techniques. You have conventional PCR, you have reverse transcriptase PCR, You have real-time PCR for quantification of the transcripts, which are currently highly sensitive and standardized techniques, very cost effective. It can assess the kinetics of MRD, as I mentioned, in BCR-able transcripts in CML. You can have the PML-RARA transcripts in PML-RARA in APMLs. And you have, these are the real-time platforms, ABI 7500, Rotogene. QuantStudio 3 is also real-time platform. Agilent Area Max is quantum, the quantitative PCR. So all four platforms are in our laboratory where we use them very, very efficiently to study large number of molecular genetic studies. Next. So you can also have digital droplet PCR. This is a Biorad, where you can have precise quantification of the target nucleic acid in the sample. Extremely good platform for rare event detection. Then you move to this NGS platform. This is the S5 of Thermo. This enables this is a platform which can do multigenic analysis, where you can do large number of, almost we have the comprehensive myeloid gene panel, where we have 69 genes studied at one go, which has got 29 fusions and 40 mutations. Out of that 40, 21 are full genes and 19 are hotspots. So extremely efficient. It can also detect mutations. It can detect single nucleotide polymorphisms. It can detect multiple nucleotide variants, insertion, deletions, and wonderful copy number variations as well. So this is a platform of the future. So next generation sequencing is the technique which most of the laboratories are going to follow sooner or later. Next. So this is how our NGS lab looks like. We have the Iron Torrent PGM, which is a Thermo platform, Iron Gene Studio S5, which I just showed you. This is also from Thermo. And this is the Illumina MySec. We have three next generation platforms in the laboratory, and we use them for solid tumor and liquid tumor molecular genetic analysis. Next. So I mentioned about the hyperdiploidy and hyperdiploidy. This is the single most important factor that can risk stratified precursor B-cell acute lymphoblastic leukemia. So you have high hyperdiploid, you have low hyperdiploid, where the chromosome numbers are more than 46. Hyperdiploid chromosome numbers are less than 46. Near haploid, where you have 23 to 29 chromosomes. So you can see that prognostically high hyperdiploid favorable, low hyperdiploid not so favorable, but still favorable than hyperdiploid. Where near haploid unfavorable. When you have deletion 7q, which is a bad prognostic cytogenetics. So this is how you will risk stratify acute myeloid leukemia and ALLs. Next. So this is the table which will tell you the risk status: favorable, intermediate, and poor. Cytogenetic factors and molecular abnormalities. In AML, if you have inversion 16, if you have 821, or you have chromosome 16 abnormality by 1616 translocation, they're all favorable. These are all core binding factor leukemias. Similarly, you have a poor risk stratified AML, where you'll have complex cytogenetics, which is more than equal to 3 abnormalities. You have monosomy 5, monosomy 7, 5q minus, 7q minus. So monosomal karyotype is poor in prognosis. You can have trisomy 8, you can have inversion 3, you can have 6, 9, and 922 translocations, both found in ALL and AML. And you can have KMT2A abnormalities, as I have described. All are poor. Anything which is not favorable, not poor, are in the intermediate category. So normal karyotype is intermediate. Trisomy 8 only could be intermediate. Other abnormalities not listed with better and poor are all intermediate. Similarly, when you look at the molecular side, you can have the FLT3 and NPM1 mutated AMLs. FLT3 is poor, NPM1 is favorable. You can have a normal karyotype or core binding factor leukemia. But if your c-KIT mutated along with this core binding factor leukemia, it is intermediate, not favorable. So you like to upfront transplant these patients rather than just go a simple chemotherapy way. So normal cytogenetics with isolated FLT3 internal tandem duplication variant or tyrosine kinase domain mutant variant are all poor in prognosis. Next. So there lies the importance of doing cytogenetics and molecular studies. So here you have two table. This table shows you two columns. You can find that one is the favorable risk molecular studies and another one is the unfavorable risk molecular studies. As I mentioned, these are all good. CBPA, alpha, NPM1, GATA1 mutations are all favorable, whereas FLT3 ITD, TKD, and c-KIT mutations are poor. Similarly, you have favorable cytogenetics and unfavorable cytogenetics. I have already described that. Next. So to summarize, the diagnosis of acute leukemia in the current era is becoming highly complex because you have to employ multimodality diagnostic approach by employing multiple techniques, right from morphology to flow cytometry to cytogenetics to molecular genetics. So I need not overemphasize that. And as the classification evolves around the WHO, it has become more and more complex for developing countries to adopt the various techniques that they pronounce. So WHO has also taken care of the developing countries by keeping, like as I mentioned, AML with morphological defined entities or differentiation with differentiation. So you can, or in the fourth edition, 2017 classification, everything becomes AML, not otherwise specified, if you do not do the cytogenetics and molecular genetics. But if you want to really prognosticate the patients for your clinicians, you need to employ cytogenetics and molecular analysis for risk stratifying the disease. Thereby, they can select their therapeutic strategy as to what they should do, whether only chemotherapy or they want to mix chemotherapy with bone marrow transplantation. Next. So with that, I thank you all. I have overshoot my time because of losing about 15 minutes at the beginning. My apologies for that. And in case any of the attendees have any questions, I would love to answer a couple of them. At the present moment, there are about 85 people listening. There were 100 plus people, and I think because it is past 8 p.m., so many of the people must have logged off. So any questions from the participants? Anything in the chat box?
Dr. Pritesh, go ahead. You need to unmute yourself.
Sir, what is the role of alert tube? Sir, very nice presentation. Thank you for the talk, sir. And, sir, what is the role of alert tube nowadays in the era of 10 to 13 color flow cytometry in the initial day?
So what usually is done in most centers these days, you have a tube which is called a lot tube. Okay. So that tube will tell you which way to go, whether it is a single tube, which is 8 color, which will tell you, or it can be 12 color, which will tell you whether this is a B lineage leukemia or T lineage leukemia or AML. So after that, you then do your panel selection based on your laboratory that is following, and then you can move to multiple tubes for studying AML or TLL or BLL. So that is how the strategy is evolving.
So the chart is disabled. Can you please enable the chart so that other people can ask?
Which one? At the chat box, yes. So there are no questions in the chat box yet.
Is it disabled? It is. Actually.
Okay. I have disabled it, no?
Dr. Aisha, can you please ask your question?
Yes, sir. Sir, very nice presentation. I just want to ask one question that in the case of CML, we mostly prefer quantitative PCR. Yes. So what about the other tests? What's the significance of this quantitative PCR related to any other leukemias?
You see, in chronic myeloid leukemia, treat them with tyrosine kinase inhibitors. Either you have imatinib, or you have dasatinib, or you have nilotinib. And once you treat them with any of these TKIs, first generation, second generation, patients are followed up on a regular basis, starting from 3 months to 6 months to 12 months. And based on that, you have complete molecular remission. So at 3 months, you should have less than 10% of the transcripts being present. By 12 months, patients should be in complete molecular remission. By that, it should be less than 0.1%. So you can only estimate this by real-time PCR, by targeting the BCR-able transcript in a quantitative manner. Either you use the digital droplet PCR or you use the real-time PCR technique to monitor these BCR-able transcripts. Okay.
Dr. Sanjeev, can you please ask your question? You need to unmute yourself.
Sir, recently I have got a patient who has 10 mutations in NGS.
Yes.
And this patient has the features of dysbiosis in all cell lines.
Yes.
How to prognosticate such patients? There is a mutation in almost every epigenetic gene like IDH2, DNMT, XL1. There is a low percentage of FLT3 mutation also.
So this is a very, very important question, a very important question you have asked. You know, when you do the multigenic analysis by next generation sequencing, you will get large number of mutations if they are mutated. So like you can have epigenetic mutations like DNMT3A, you can have SLX1, you can have IDH1 and 2, you can have SRSF1. I showed you those 8 genes. So possibly what you are describing, you have a patient of acute myeloid leukemia with myelodysplasia related changes, because many of these are MDS related cytogenetic and molecular genetic abnormalities. So when you treat such a patient of acute leukemia, the treatment outcome is grim, and you need to transplant this patient once you induce this patient with induction regimen, and you should upfront transplant them to have better outcome.
Her elder sister has also expired of blood cancer. Probably he has having some germline mutations.
Yes, you can have, you see, if you see the WHO 2017 classification, the first category of AML myeloid malignancy is acute leukemia with germline predisposition.
Yes, sir.
So in that category, you can have RUNX1T1 mutation.
Yes, sir. RUNX1 is also there, and B4 is also there.
B4 is also there. You can have DDX4 also is there. So there are certain gene mutations which can be germline. And once you have a germline myeloid malignancy, the prognosis is poor, and you need to transplant such patients. And in this case, it should not be sibling-related transplant, because it is expected that your sibling also could have this germline mutation. So it will be
yes, sir. Yes.
You verify the mutation status in the sibling, and or you have to find a matched unrelated donor transplant.
Yes, sir.
Dr. Ashwin, Dr. Ashwin, please go ahead with your question.
Yes. First of all, thank you, sir, for such an informative and knowledgeable talk. Sir, my question is that I've been doing the bone marrow procedures as well as reporting morphology, because in my setup, like flow cytometry facilities are not there. So what happens on a rare occasion? Sometimes the aspirate are hemodiluted. So, sir, in which conditions we can send the peripheral blood sample if it has atypical cells or blasts for flow cytometry or cytogenetics? In which of the leukemias do you suggest that if unfortunately the bone marrow aspirate is hemodiluted, or maybe it is a dry tap, we can send a peripheral blood smear for the cytogenetics and flow cytometry? Very,
very good question. You see, many times what happens when you have AML with fibrosis, you may have a blood tap or a dry tap, and your cells will be very few. So that may not be sufficient enough to make a morphologic diagnosis, but you see blast in them. So you know that it is acute leukemia. So in that situation, if your peripheral blood has got good number of blasts, you certainly can do FISH in them.
Yes.
And the karyotyping from peripheral blood blasts are not so good as the bone marrow blasts, but still they can grow. So you must try conventional karyotyping. If there is more than 20% blast in the peripheral blood, you can do a FISH analysis also with known markers, known probes. And if the blasts are more than 50%, certainly you can subject it to NGS as well as Sanger sequencing for gene analysis. You can do FLT3 NPM1 with that 20% blast in the peripheral blood. So what we suggest
Yes.
you can do a Buffy code preparation, a Buffy code
Okay.
using
Okay.
an ml of blood, centrifuge them and collect the Buffy code, which will have the concentrate.
Okay. Okay. That is a great idea, sir. Yes. Hello. Yes.
That will be much better.
Yes, sir. Yes. And lastly, sir, just a small request. In your Tata Medical Center, which is a reputed institute, is there a facility of something like an observership or a small fellowship for practicing pathologists like us?
Yes, all the time we have observers. Even now we have
Okay.
a professor from Lady Harding. We have many other observers coming in from all over the country.
Sir, I am from Guwahati, Assam, practicing in Apollo Guwahati. I am from the old school, like I am DCP plus with 12 years of experience. Would I be eligible for an observership or a fellowship?
You don't discriminate with that. So you are always welcome. You can just mail me and we will certainly consider you for a 2-week, 4-week observation.
Sir, how can I have your mail address?
I
Email address?
Slide at my mail ID. It is deepak.mishra@tmckolkata.com.
Okay, sir. Thank you so much. I'm really grateful.
Okay.
Thank you.
You're most welcome.
Sir, in this report, we get a lot of mutation as you have already mentioned, but how to differentiate between which mutation is of clinical significance, how much VAF is required to identify this of clinical significance, and how to differentiate between germline or not?
Very important question. Very, very important question. So when you do NGS, you will get something called variant allele frequency. Okay.
Yes,
usually in our center, the cutoff is 5%. So we don't report any variant allele frequency to be positive if it is less than 5%, because it could be noise, molecular noise. Okay. But if you have error corrected ultra deep sequencing, you can go right up to 1%, 2%. So you have something called CHIP, clonal hematopoiesis of indeterminate potential. So there it says that you can find CHIP which are less than 2%. Okay, so in what you describe, that usually the variant allele frequency is less than 50%. If it is around 50%, you could think about a germline mutation. Okay, so in that case, you should do a buccal swab to study the germline genes. Otherwise, if it is 20%, 25%, 30%, it would be a somatic mutation. So around closer to 50%, you may suspect germline mutation.
But it's less than 50%.
Less than 50%, 40%, 45%, you can be, you can consider somatic mutation.
Okay.
Dr. Sujay, please go ahead with your question.
Yes. Any more questions?
Dr. Ashwin, please unmute yourself.
So I'm quite delighted that people are quite receptive.
Yeah. Yes, sir.
Yes.
Dr. Sujay, you need to unmute yourself.
Yes.
Yes.
Dr. Sujay, are you there? Yeah, please go ahead.
Yes, I am here. I like to ask a question, sir. Actually, sir, I completed my MD pathology in 2016, and I have an experience of 6 years, but I have very limited knowledge regarding flow cytometry or genetic analysis, cytogenetics, just little bit book knowledge. Okay.
Do you have a flow cytometer in your lab?
Hello?
Do you have a flow cytometer in the lab in which you are working?
No. I am working in a government setup. This is a going to be newly established medical college, and thing is there 3 4 private labs. Nowhere flow cytometry instrument is there.
So even then, you are most welcome to experience in flow cytometry. You can do a observership of about 4 get a fair amount of work.
Okay. I like to know about little bit flow cytometry and what are the genetic mutations are significant.
Where is your college?
Hello?
Where is your college located?
I am posted at Uluberia Subdivision Hospital. Now
yes.
it is known as Sarat Chandra Chattopadhyay Government Medical College.
So that is
in
West
Howrah.
Bengal. You are most welcome. You are not far away. You just have
Yes,
to.
sir.
Yes. So we
Okay.
just had an observer from ESI Hospital Joka. Another observer
Okay, sir.
from ESI Hospital Sialda.
Okay, sir. How to apply for that?
You just send a mail and we will
Okay.
find a slot for you because we don't want to overcrowd the laboratory. We always have 1 or 2 observers in every area of our lab. Either flow cytometry or cytogenetics or molecular genetics, we have maximum 2 observers working at one time. So we will give you a slot. Based on
Course duration, sir? Course duration?
2 to 4 weeks is ideal for flow cytometry.
Okay, okay, sir. Can I get your mail ID?
Deepak.mishra@tmckolkata.com.
DIPAK, Deepak.
DEEPAK.
Deepak.mishra
@tmckolkata.com.
Deepak.mishra@tmc.kolkata.in.
TMC Kolkata, one word.
tmckolkata.in.
.com.
Okay. Thank you, sir.
Dr. Swapnil, please go ahead with your question.
Myself, Dr. Swapnil Chandekar, sir. I
Yeah.
am working in a research area, research institute of ICMR at remote of Chandrapur district, Maharashtra.
Oh, yes.
We have having facility of flow cytometry.
Yes.
Now, just I want to ask, you can provide some guidelines or something so that we can work for AML or blood cancers related this in our institute.
But are you getting clinical samples in your research lab?
Yes, sir.
If you're getting clinical
We
samples,
can start with new project.
no,
If some plans are there.
patient diagnostic work or it is research work?
It's a research project.
So research project, if you have a flow cytometer, we can teach you the fundamentals of flow cytometry. How
Okay,
to
sir.
use the flow cytometer, so you can always come. But the thing is that if you want to do diagnostic flow cytometry, you need to have patient samples. Okay.
No, we are working for a research institute.
So where from you get the samples?
From medical college. We have just tie up with the medical college, government medical college.
So you can offer diagnostic services to medical college. They may not be having a flow cytometer, but you have.
They are not having the flow cytometer.
You can extend the diagnostic services to them. So that's more
Yes,
the why you should get trained and you use that flow cytometer for the good of people and patients.
Okay, sir. Thank you.
Good idea. You can always get yourself trained and start doing it.
Dr. Sujay, go ahead. Dr. Sujay, you need to unmute yourself.
Yes, sir. I don't have any question. Okay, thank you, sir.
Okay.
Thank you very much. Thank you, sir. Thank you very much for your time, sir.
I think we have come to the end of question answer session.
Yes. No more questions are there, sir.
Okay, and 52 people are now in the audience.
Yes, sir.
So thank you very much.
Thank you, sir.
Thank you very much, Khushi.
Thank you, sir. Thank you very much. Very nice.
Thank you very much, sir.
Yes, thank you very much. In case you have any queries still, you can always mail me. Okay.
So one last query, 1 second.
Yes.
So for an observership in TMC, your institute, like for morphology experience and training, sir, I would just like to know, do you have a pentahead or a this thing for, so that people can learn from you, your expertise?
No problem. We have all our consultant microscopes are double header and we have triple header for reporting.
Thank you, sir. Okay. I shall keep in touch with you through email.
Surely, please.
Thank you so much, sir.
Thank you, Deepak, sir.
Thank you, Praveen.
Thank you, sir.
Thank you. Time to log off.
Yes, sir. You can.
Thank you very much.